All right. Good afternoon, everyone. It's good to see you. I hope you're doing well. Put a little hiatus since I've been in here, but hope, and I think for you too, right? It's been a couple of days, right, since last week. What we're going to do today, we've got a lot of work to do today, okay, and tomorrow. So I'm not going to sugarcoat it. There's a lot to go over. But it's very interesting, and we're going to start to, as we explore the disease state or disease states that we refer to as ischemic heart disease, right? We're going to start to build on our foundations of drug knowledge that we've been developing as we've talked about hypertension and dyslipidemias, and we're going to continue adding different types of drugs and drug classes into your toolbox here, so that you can get a more complex picture of all of the different drugs that we use to treat the variety of cardiovascular diseases. I have about 3 hours for this particular block of instruction. I'll go into tomorrow, and Dr. Naeem will pick up towards the end. Let's talk a little bit about some learning objectives here to kind of frame things, because it can be overwhelming. But I want to, hopefully provide you with a basic framework, again, that you can work from that will help you keep things kind of organized and, categorized in your mind so that you don't get too confused about things. So, when we talk about ischemic heart disease, the first learning objective is so important, okay? That really deals with explaining the importance of balancing the work that your heart is doing. Remember, your heart is essentially an organic pump, right? And its job is to move blood throughout the peripheral circulation. And it does every minute of every day. It's doing a certain amount of work. And that work varies, right? Right now, as you're sitting down there and getting comfortable for lecture, it's doing a certain amount of work to move blood through your circulatory system. If you would happen to stand up very quickly and run up and down the stairs 5 or 6 times, the work that your heart is going to do is going to increase dramatically. So, and it's going to have to work harder to pump more blood throughout the circulatory system. So the one thing I want you to understand is that the work that the heart does is not constant throughout the day. It's variable, all right? And that should make sense depending on the demand that you're putting on it. Now, the body, under normal circumstances, does a really great job of balancing that work, okay, with essentially the fuel that the heart needs in order to function, and that fuel is oxygen, okay? It's a bad analogy, but I think it'll help us to really kind of think about all of what we're doing here, right? As your car goes faster and it does, and it generates more power, it uses more gasoline, right? There's that kind of balance between those two things. Your heart is the same way. As it does more work, it's going to demand and need more oxygen. And so balancing that is super important, because if it gets out of balance, if that relationship gets out of balance, it can cause ischemia. Right? And ischemia is a condition of low oxygen delivery to tissues, okay? Or inadequate oxygen delivery to tissues. I think that's a better way of phrasing it. An inadequate oxygen delivery to tissues, and in this case, the heart, okay? And we're going to explore that a lot more here in the next slide or two, so you can get a sense of what's going on. We are going to identify and categorize the drugs that we're going to talk to throughout this entire long lecture into 2 categories, okay? Drugs that reduce cardiac work, okay? Any drugs that reduce the amount of work that the heart has to do, and there's a variety of ways we can reduce the work that the heart has to do, will fall into one category. The other category, broad category, we're going to clump drugs into or categorize drugs into are drugs that improve cardiac blood flow or coronary blood flow, okay? And some drugs actually do both, and they fall into both categories, okay? So at a very baseline level, it is critical that as we go through all of these drugs, that you can, at a minimum, place them into one or both of these categories. Okay? If you can do that, it really helps in understanding not only how they work on a cellular molecular level, but also understanding their role in therapy. Okay? In terms of specific drug classes, we're going to talk about the role and mechanisms of nitric oxide in the body, and how it can help regulate the tone, okay, or diameter of your veins and arteries. In hypertension, we talked a lot about angiotensin II as being a powerful vasoconstrictor, or norepinephrine, all right, a catecholamine that your body makes, as a powerful vasoconstrictor. A vasodilator, a powerful vasodilator that the body makes, is called nitric oxide. And we have essentially drug forms of nitric oxide. It's not that simple, but we have drugs that contain nitric oxide called the nitrates. And we're going to talk about how they work by releasing nitric oxide into the bloodstream. Then we're going to shift, after we talk about drugs that are really involved in reducing cardiac work and maybe improving blood flow, we're going to move into the categories of drugs that are solely focused on improving coronary blood flow or oxygen delivery to the heart. Okay? We're going to start talking about antiplatelet drugs. Okay? We're going to talk about the clotting cascade. Okay? And talk about how certain drugs actually prevent blood clotting from occurring. And so we're going to have to take some time to really talk about the process of blood clotting and review that a little bit, because you covered that with Dr. Joshi in Biomed, I'm sure, okay, to some degree. Remember talking about the clotting cascade, right? All right. So we're gonna refresh your memories on that. We're going to talk about the structure-activity relationships of drugs that are used to treat ischemic heart disease. Good news for those people that aren't big med-chem fans. Not a lot in this particular lecture. It's more pharmacology, physiology, pathophysiology stuff. There'll be a little bit, but nothing like we had before. And then we're going to talk about the molecular mechanism of actions of drugs used to treat ischemic heart disease and their effects on their relevant tissues and organs. So a lot to go through here today. All right. I've got the drug index here, okay, and the various classes of drugs that we will cover today. One of the things that I, kind of off topic but related, and I don't know if anybody's talked to you about this or not, but as we were talking with the recently graduated P4s, one of the things, and even the class from the previous year or two, one of the things that they really struggled with on the NAPLEX is brand names. Okay? Have you heard that before? Has anybody talked to you about that? If they haven't, I want to bring that to your attention. Okay? I think we've done a lot of really great things in changing around how we teach the top 200 and assess you on that. But I want you, as you're going through pharmacotherapeutics, especially this semester, because you're going to cover a lot of commonly used drugs, really learn the brand and generic names. Okay? They're really super important. So we've got the organic nitrates that we're going to talk about. Okay? These are drugs like nitroglycerin or isosorbide dinitrate or erythritol tetranitrate. We're going to talk about our old friends, the non-dihydropyridine calcium channel blockers, diltiazem and verapamil. We're not going to be talking about the dihydropyridines today, only the non-dihydropyridines. Okay? We're going to talk about a drug generically classified as an anti-anginal agent. Angina essentially refers to chest pain associated with cardiac ischemia. And ranolazine is a drug that has a very unique mechanism of action that doesn't fit in any of these other categories, so we call it an anti-anginal agent. Beta blockers, again, Dr. Naeem is going to talk about beta blockers and their role in treating ischemic heart disease. We've got anticoagulants. We're just going to start touching on this. We have a whole other lecture on anticoagulants and things like venous thromboembolism, pulmonary embolism, those sorts of things. coming up a little bit later in a couple of weeks. So we'll touch on that very briefly and get the very basics, and then we'll move away from it. We're going to spend much more time talking about antiplatelet agents, and I'm going to explain why. We cover one more heavily here than the other, and it's related to ischemic heart disease and some of the disease processes that are going on. Okay. We will talk about glycoprotein 2B3A inhibitors, okay? And these are another group of antiplatelet drugs. We're going to talk about thrombolytics very, very briefly. These are drugs that break up arterial clots. And then direct thrombin inhibitors, another type of anticoagulant. So a lot of things going on here with regards to drug classes, and I'll try to keep it as simple and focused as possible. All right? And please don't hesitate to stop me if you've got questions. All right? All right, so let's get into it. We've already defined kind of what ischemic heart disease is. For those of you that weren't here or maybe we're not really focused in yet, ischemic heart disease is a condition where oxygen flow or delivery to the heart is impaired in some way. Okay? And there's a couple of different ways why oxygen delivery to cardiac tissues can be impaired. And then when you run into a situation where the work that the heart is doing and its demand for oxygen exceeds the ability of the body to give it oxygen through the coronary blood supply, that's when you start to experience, angina, chest pains. It can get worse and actually develop into a full-blown, cardiac heart attack. Okay, and so myocardial infarction. And Dr. Naeem is going to talk about that. But what I wanted to talk about today were some of the different causes of myocardial ischemia. Really, really basic stuff. What are some things that can block up or impair blood flow through the coronary circulation? Remember, coronary circulation or coronary arteries are blood vessels that feed cardiac muscle tissue with blood and oxygen. Okay. The coronary circulation actually begins at the base of the aorta. So the heart actually receives the most oxygenated blood in the body. It's coming fresh from the lungs, right out of the left ventricle and into the aorta, at the base of the aorta. And there's a coronary vessel that comes out of the base of the aorta that delivers this highly oxygenated or enriched blood to the heart. Okay. Now, there are three different types or three major reasons. Okay. Why the large surface coronary arteries, we call those epicardial coronary arteries. These are the ones that you can see when you look at a picture, cartoon picture, a real picture of the heart right on the surface. The three major reasons how these blood vessels can be blocked. Okay. The first one is the one we're probably going to focus the most on here. Okay, and that is the process of atherosclerosis. And Dr. Naeem is going to talk a little bit about that. It is definitely connected to dyslipidemia. Okay, we are not 100% sure why atherosclerotic disease occurs. We know that we know parts of the process. We have an understanding that, again, dyslipidemia can be a major cause of it. It's involved in some way, but it's not the only thing. Okay, there's a lot of question marks still there. All right. So what Dr. Naeem will probably present to you is kind of our current theoretical model, what we think we know is going on in the blood vessels. But what we do know very clearly, okay, is that over time in certain individuals, especially as you get older, if you don't exercise often, you don't have a great diet, there's a lot of risk factors for atherosclerotic disease. You smoke, those sorts of things. Over time, what can happen is you can get the formation of what we refer to as atherosclerotic plaques in the coronary circulation. And in fact, plaque formation can occur in any vessel, artery throughout the body. Okay, that would be referred to as peripheral artery disease. So oftentimes we think about atherosclerosis and the formation of plaque. We really just think about what's going on in the heart. But the reality is in peripheral artery disease, this process can occur in any of your arteries or blood vessels throughout the body. Okay? Now, as Dr. Naeem is going to talk to you, there are two different types of plaques that can form in the coronary circulation. Okay? These are called stable and unstable plaques. Okay? Of the two, you've got to have one. Okay? You want to have a stable plaque. Okay? This is a plaque, as the name implies, it's got a high degree of stability. Okay? It doesn't change. Okay? It doesn't rupture or break open like a vulnerable or unstable plaque would. Okay? So a stable plaque is kind of it's a solid structure in the arterial circulation, the coronary circulation. It can grow and get larger over time, but it is highly unlikely to rupture and spill out its contents into the bloodstream, whereas a vulnerable or unstable type of plaque can do that. And these types of plaques are what, both can cause myocardial infarction, I believe, but the unstable, vulnerable plaques can cause that to happen very rapidly and maybe even unpredictably. Okay, because what happens is an unstable plaque can break open, spill out its contents into the bloodstream, and you can start to get a clot that forms there very, very quickly, which can totally occlude or block the blood vessel. Okay? Versus a stable plaque that you can observe and measure over time. It may get to the point where it's blocking 70, 80, 90% of the blood vessel, and you might have to have a stent put in or other type of procedure done. But it's unlikely to break open or rupture and cause a rapid occlusion of blood vessels in the heart. Yeah.
Still, like, if you still have like that plaque in the coronary artery, it will still like have an impact on the heart.
It can.
Right?
Yeah, absolutely. Right. So a plaque is sort of like a partial blockage, and it can actually fully block a blood vessel. Okay. So depending on the size of the plaque and how large it is, will determine how much blood it's impairing in terms of blood flow. Right. How much blood is it blocking from flowing through that segment of the coronary artery. Small plaques don't have much impact. Large plaques can block 70, 80, even 90, or 100% of the blood vessel, depending on how large they grow. But they grow slowly over time versus a vulnerable or unstable plaque that could rupture at any time. When that happens, your hemostatic mechanism kicks in, your blood clotting mechanism kicks in, and that clot that forms around that ruptured plaque can very quickly occlude a blood vessel.
Yeah, that was my second question. When you have like a vessel that is blood, you have like this hemodynamic like instability which can cause like clotting, right?
It can too, right? So and again, not to say that you can't get clotting around a stable plaque. You're absolutely right, Ernesto, about that. A stable, if you think about a blood vessel, an artery, whether it's coronary artery or another artery, the interior of that artery is very smooth. Okay, it's lined with endothelial cells. It's very, very smooth, which allows for laminar blood flow. Okay, but when you get a plaque that starts to form in an area of an artery, okay, that can cause turbulent blood flow. And that can actually activate the clotting cascade, and slowly over time, you can get a clot that forms there that can impede it. The unstable plaque, and Dr. Naeem will talk more about this, if it happens to rupture, okay, the clotting process that occurs there is very, very quick, okay, and can occlude a blood vessel very, very quickly. Okay, good question. Dagmara.
So when you compare the stable plaque versus the
unstable or vulnerable plaque, yeah.
I mean, still, the stable plaque is a bad thing, right?
They're both bad things. Yeah, you don't want them. You want to keep your blood vessels as healthy as possible, right? But if I had to choose, if I had to have one or the other, okay, I'd choose a stable plaque that, maybe doesn't include your artery very much, right? Because it's unlikely to rupture, break open, and form, a clot very rapidly, causing MI. Okay?
Does it contribute to the part of the
They can, they both can. Anything that blocks blood flow or reduces blood flow in the heart can cause ischemic heart disease, whether it's a stable plaque or unstable plaque, doesn't matter. Okay? The only difference is one could rupture very easily and break open, and that can activate the clotting system very quickly and cause a rapid emergent clotting of the blood vessel, which can cause an MI. The other one, the stable plaque, you can get clot formation there slowly over time. It will grow slowly over time, but you can monitor it, right? So if you've got coronary artery disease like this, you're probably seeing a cardiologist yearly. They might do a stress echo or things like that, where they can actually look at your blood vessels, look at the blood flow, and make sure that everything, they kind of measure how things are progressing. Okay? Does that make sense to everybody? And Dr. Naeem's going to talk a lot more about that. Okay? But both can cause ischemia. Okay? So, for example, down here, if we take a look at the stable plaque, any kind of blockage in the artery can reduce coronary blood flow. We know that. And the reduction in blood flow is dependent on how large the plaque is, right? Now, you can get something called demand ischemia with this. All right? So let's say one of your coronary arteries has a stable plaque in it that is occluding the artery by 50%, blocking half the blood flow that would normally go through that coronary artery. Let's say I have that. Okay, and I hope I don't, but let's say I do, right? I'm walking around here and I'm teaching and I'm pretty relaxed, right? I'm probably not gonna have any chest pain or any type of, symptoms of ischemia, okay? But if I go jump on my mountain bike after work and go ride for 2 hours, right? That could cause ischemia because the amount of work that my heart is doing will far exceed the ability of that coronary artery to deliver blood to that part of the heart. Does that make sense to everybody? There's a blockage there, okay? Sort of like you have in your car, you have a big gas tank in the back, right? And then you've got a fuel line that takes the gas from the gas tank to the engine, right? Okay? If you were to pinch off or squeeze that fuel line a little bit and occlude it, right? That's going to limit the amount of gasoline that your engine's getting, right? So if you need your car to go really fast or work really hard, and under those circumstances, it's not going to happen because it's not getting enough gasoline. Make sense? Okay. With a vulnerable plaque, like I said, what can happen is you can get something called, a vulnerable or unstable plaque. The plaque can rupture. They refer to it here as plaque disruption, and that can lead to the formation of a thrombosis or clot. All right, and that can occlude or block a coronary artery very quickly, which could lead to acute coronary syndrome or a myocardial infarction. Dr. Naeem's going to talk all about those. Okay? So this is the one we're going to focus on. Over here, we have the second cause for ischemia, which is vasospastic disease. Okay, so this is kind of uncontrolled constriction of your coronary arteries that, again, as they constrict, and if they constrict too much or in an uncontrolled way, they can block blood flow to certain regions of the heart. Okay? And again, we won't talk too much about this. There are two different types, focal transient vasospasm, okay, that, again, only happens occasionally and in a very localized region of the blood vessel. And this can cause a type of angina called Prinzmetal angina. Or the other kind, which is more serious, is kind of a persistent vasospasm, where you've got a coronary artery that's spasming. It's constricting and relaxing and constricting and relaxing a little bit. It's going back and forth. And when it constricts, it really constricts down hard and reduces blood flow to parts of the heart significantly. And that can lead to a myocardial infarction. Okay? And then we have something called dissection here, where you get a tear in the endothelial layer of a blood vessel, also referred to as the tunica intima. That's why they refer to it as an intimal tear up there. It's just a tear in the endothelial layer. And you get a little flap, okay, tissue that can actually start to occlude blood flow or block blood flow, as you can see down here. And as a result of this turbulent blood flow here, you can start to get a blood clot that forms around that intimal tear. And eventually what that will do is form a complete thrombus or clot. And again, it can partially or even fully occlude an artery, and that can lead to again, problems with acute coronary syndrome, or even in severe cases, a myocardial infarction, okay? And again, what I want you to understand is it's not it's not one or the other, okay? These can all mix together, so you can have multiple issues going on. You can have a region of your coronary artery that's got a plaque in it, and also it can vasospasm. That's even worse, right? If you've got two of those issues, you can very quickly occlude blood flow to different regions of the heart, okay? You could have a dissection plus vasospasm. So, you have a combination of all of these. This is all happening in those large surface epicardial coronary arteries. Now over here, in the coronary microcirculation, these are in the arterioles, in the much smaller, tinier arteries. You can get what we refer to as microvascular dysfunction, okay? So occlusion of not only the large coronary arteries can occur, but blockage of these microvessels can, okay? And again, this can also cause ischemic issues in patients. So, any type of artery, whether it's a large epicardial coronary artery or a smaller arterial or part of the microvascular circulation of the cardiac tissue, can all cause problems here. Okay? Now, as I pointed out, there are two components to ischemic heart disease, and we're going to use drugs to manipulate one, the other, or both of these characteristics or components. Okay? So the first one we're going to talk about, the first pharmacological strategy that we can use to treat ischemic heart disease is to improve coronary blood flow, right? Everybody here had economics, right? Okay, and we've all heard of the supply-demand curves, right? Okay, supply and demand. Right? Okay, if supply is low and demand is high, what happens to prices? They go up, right? Okay, if supply is high and demand is low, prices go down, right? Well, if you could think like that, you can understand ischemic heart disease. So if you have a situation where coronary blood flow is low, okay, and demand is really high, that's a problem, isn't it? Right? We want them balanced, okay? And so, again, we can use drugs to improve coronary blood flow or reduce oxygen demand by lowering or reducing the work that the heart has to do. And that's our goal, is to bring that equation back into balance using drugs, because it's out of balance in patients with coronary artery disease. Okay? Make sense? Okay. So, drugs we can use to improve coronary blood flow. Nitrates, okay? Non-dihydropyridine calcium channel blockers, okay? Both of these groups of drugs will dilate coronary arteries, make them larger, allow them to relax, okay? Ranolazine will actually allow coronary arteries to dilate as well, but its mechanism is very, very different than those other two classes, okay? But it essentially will allow coronary arteries to relax and open up and allow for better blood flow. And I'll talk about how that happens later on. Then we have all of our hemostatic agents here, okay? These are drugs that can deal with clots that form in the coronary arteries, either by preventing them from forming, okay, or by removing them, okay? So our antiplatelet agents and our anticoagulants can be used to prevent clot formation, okay? And the thrombolytic agents are sometimes referred to as clot busters, right? They break open clots or chew up clots or break them down, okay? And under certain circumstances, they could potentially be used to open up a coronary artery and improve blood flow, especially if someone's having a myocardial infarction or heart attack. Okay? Everybody got that? All right. Down here, we have drugs that reduce cardiac work. Okay? Telling the heart to sit down, chill out. Okay? That's essentially what they're doing. Reducing cardiac work, and as a consequence of that, the demand that the heart has for oxygen goes down. The less work it does, the less oxygen it needs. And even if you don't improve coronary blood flow, you might be able to help reestablish that balance, right? By bringing work down and oxygen demand down. And you'll see that a lot of our drugs, not only do they improve coronary blood flow, but they also reduce cardiac work. The nitrates do that, okay? The non-dihydropyridine calcium channel blockers, not only do they improve coronary blood flow, but they also reduce the work the heart has to do, okay? And I want you to start thinking about that. You know, how might non-dihydropyridine calcium channel blockers reduce the work and oxygen demand of the heart, okay? Beta blockers do that as well. They reduce cardiac work and as a result, reduce cardiac oxygen demand. And then we have ranolazine, which also reduces cardiac work and oxygen demand. Okay, everybody got that? So again, this is a key big picture slide here. If you're confused, start with this. Listen to this slide over again and then start digging into the individual drugs. Because this is the foundation that you have to work from. We'll keep coming back to this. Okay? Everybody got that? Any questions before I move on? You guys feel good about that? Feel like moving on? All right. Now, first group of drugs we're going to talk about are our nitrates. All right? Our nitrate drugs. Before we talk specifically about the drugs, I just wanted to do a brief review / overview of the nitric oxide pathway, okay? So nitric oxide is a gaseous neurotransmitter. It's the only one that like it in the body. It's the only gaseous neurotransmitter that I'm aware of in the body. It has an extremely short half-life and is produced by the endothelial cells that line the interior of your arteries, okay? They're the cells, these cells have special enzymes that allow them to make nitric oxide, okay? The stimulus for these cells to produce nitric oxide are activation of muscarinic and bradykinin receptors, M1, M2, and B1 and B2 receptors. I don't know what that F is up there for, I think it's a typo. Okay, but muscarinic and bradykinin receptors, when they get activated on endothelial cells that line the inner surface of your arteries, that will cause production of nitric oxide. Okay, the enzyme that produces nitric oxide is an enzyme called nitric oxide synthase. Okay? And there's a couple of different kinds of NOS that you'll find throughout the body. Okay? But there's one specific for endothelial cells. Just FYI, I won't ever test you on it, but that type of NOS is referred to as lowercase e NOS. E stands for endothelial. Okay? Now, this enzyme here, the substrate that it acts on is the amino acid L-arginine. So nitric oxide synthase, when it's turned on, will bind with L-arginine and split it into two separate molecules, a nitric oxide molecule and a byproduct called L-citrulline. So nitric oxide actually comes from an amino acid that our body has, L-arginine. Okay? If you go over here to this cartoon picture, okay, it's a cross-section of a blood vessel, okay, an artery. And we can see the different layers of the artery, okay? We have the fibrous outer layer right here represented by this black line, okay? If you remember, that's the tunica adventitia, okay? Kind of protects the artery. It's very fibrous and tough. We have the middle layer here, okay, which is comprised of smooth muscle cells that can constrict and relax and change the diameter of your arteries. And then we have that inner layer of endothelial cells that you can see right here, okay, right here. And this empty space in the middle of the artery is referred to as the lumen of the artery. That's where the blood flows, okay? So what this picture is showing is that when M1, M2, B1, or B2 receptors get activated in these endothelial cells, that can stimulate nitric oxide synthase to manufacture nitric oxide from the substrate L-arginine. And when that nitric oxide is made, it diffuses very quickly out of the endothelial cells and into the adjacent, meaning next to, smooth muscle cells, okay? And the nitric oxide can activate mechanisms inside the smooth muscle cells that will tell them to relax, okay? So nitric oxide is a powerful vasodilating agent. It's got a very short half-life, it's very lipid soluble, so once it's produced, it can freely diffuse into surrounding smooth muscle cells and cause those cells to relax, okay? Now, vascular effects of nitric oxide. This is so important, star this, because this is the basis for how your nitrates work. Nitric oxide will dilate both arteries and veins, okay? It's actually a very good venodilator, okay? Venodilator. So it relaxes arteries. If we relax arteries, what happens to systemic vascular resistance? Does it go up or down? It goes down, right? What happens to afterload? It goes down too, right? And do you think that might make it easier for the heart to pump blood through the arterial circulation if afterload and vascular resistance goes down? Yeah, so this is what we have to start thinking now, okay? All right, now, let's get into the drugs, okay? Our nitrate drugs, our nitrate-based drugs here, okay? Organic nitrate dilator agents. So there's a couple of different compounds in this class. I've got three of them up here, okay? We have nitroglycerin, isosorbide dinitrate, and erythritol tetranitrate, okay? Let's take a look at these structures again on the next page here, okay? So we can see some of the basic structure-activity relationships with them, okay? So all of these drugs are referred to as polyol organic esters of nitric acid. So they're all, they're all based upon a nitric acid structure. And they've got multiple nitrate ester groups, okay? That's characterized by a carbon, oxygen, and NO2 group. So for nitroglycerin, you can see we've got 1, 2, and 3, okay? In erythritol tetranitrate, we've got 4. 1, 2, 3, and 4, okay? And then in isosorbide dinitrate, we've got 2, okay? That's where your nitric oxide comes from in these drugs, okay? The nitrate groups serve as nitric oxide donors. So once you take these drugs, okay, and they enter into the body, they're acted upon by an enzyme, which we'll talk about on the next slide, that actually enzymatically removes nitric oxide from the drug molecule. And then nitric oxide will then act just like nitric oxide produced by your endothelial cells. It diffuses into smooth muscle cells and causes those cells in smooth muscle and arteries and veins to relax, and that has some important hemodynamic effects that we're going to talk about. So again, from a med chem standpoint, all I would want you to be able to do here is to pick out the functional groups that are nitric oxide donors here, okay? Hopefully, so if I give you a nitrate vasodilating agent, I would ask that you were able to identify this structure right here as a nitric oxide donating group, okay? Okay, so pretty easy. All right, as I mentioned to you before, these drugs are essentially prodrugs, okay? The organic nitrate dilating agents, they're prodrugs. So they needed to be acted upon by an enzyme in order to release the nitric oxide that they have as part of their chemical structure. And that enzyme that does this is called glutathione S transferase, or GST, okay? This particular enzyme, as you can see down here, I have nitroglycerin. You can see the 3 nitrate groups here, okay, that donate nitric oxide. And it's acted upon by glutathione S transferase, okay? And what you end up here is with the nitroglycerin molecule that has donated its nitrate groups, 1, 2, 3. And these nitrate groups are unstable and will break down into oxygen-free radicals here and nitric oxide here. So this is a spontaneous reaction. This is an enzymatic reaction that occurs first, okay? Glutathione S transferase utilizes sulfhydryl groups that are found on different organic molecules inside of cells, okay, to catalyze this first reaction here, okay? And there is a phenomenon where patients become resistant over time to the effects of the nitrate vasodilators, especially if they're given, in the emergency room, maybe IV, or over a long period of time. The sulfhydryl groups that are an important cofactor here for this enzyme can get depleted in cells, and this reaction will then slow way, way down. And the amount of nitric oxide that's liberated from the drug molecules will go way, way down, and the effects of the nitrates will start to dissipate. Okay? And again, you can deal with this by stopping the drug, allowing the cells in the body to replenish their sulfhydryl groups, and then the drug molecules will become more effective. And Dr. Naeem may talk about that when she talks about this. But bottom line is nitrates are prodrugs. They have to be enzymatically activated by an enzyme called glutathione S transferase, which liberates the nitric oxide molecules from the drugs. Okay? Any questions about that? All right. Now, here's the real important stuff. Okay? If that last slide was 1 or 2 stars, this is 3 or 4 stars here. Okay? So from a hemodynamic standpoint, how do these drugs work? Okay? Well, they are really, really good venodilators. Okay? So they dilate these large veins in your body. They also dilate arteries in your body, to include coronary arteries. Okay? And we'll talk more about that in a minute. But let's get back up here to venodilation, which is its primary effect. When your veins dilate and relax, their capacity to hold blood increases, right? Venous capacity increases. And that has a specific effect on the amount of blood going back to the heart, which we refer to as venous return, right? So as your veins dilate, venous capacity increases, but venous return decreases. That in turn, okay, has an effect on preload, the amount of heart in the left ventricle prior to contraction. The less blood coming back to the heart, the lower the preload. The lower the preload, the less work that the heart has to do in order to pump blood through the systemic circulation. So the venodilating effect of your nitrates can reduce cardiac work. Okay? Everybody got that? Now, the second effect on the arterial circulation is that it causes, nitrates can cause vasodilation, okay? And in fact, just so you're aware, and Dr. Naeem will talk about this, there's a dose-dependent effect on your vasculature here, okay? You know, at lower doses, you tend to see dilation and relaxation of arteries, and especially arteries in your brain, okay, and in your skin, meningeal arteries and on your skin surface. And that can lead to two common side effects with your nitrates, right? What are they?
Itching.
Flushing and itching, right? What else? Headache. Yep. Okay. And again, that's due to, again, rapid, excessive vasodilation that can occur at lower doses. As you start to bump the dose of your nitrates up, then you start to get the vasodilating effect. Okay? Now, vasodilation also decreases cardiac work, but it does it differently. It does it by reducing afterload. And if afterload is a term that you don't like, just put SCR in parentheses right next to it. It's the same thing. Okay? Anytime we can make it easier for the heart to pump blood through the circulation, okay, by reducing vascular resistance, we reduce work. Okay? I mean, and when I think about it, you know, I think in the different ways that we can reduce cardiac work. Okay, you got a little space on your sheet or whatever, you can maybe write this down. Okay, as I'm thinking about this. One major way to reduce cardiac work is obviously reducing afterload or systemic vascular resistance. That's a great way to reduce the work that the heart is doing and thus reduce its demand. So that's the first thing. Okay. Second thing, okay, is what we talked about up on top here. All right. If we can reduce cardiac preload, we will reduce stroke volume and cardiac output, right? Okay. And there's a couple of different ways to do that. One of them is vasodilation. We just saw that up there. The last one, I'll let you catch up here a little bit. So we have reducing afterload, reducing preload, which will reduce stroke volume, cardiac output. Cardiac output is a measure of the work that the heart is doing. So reducing cardiac output. Everybody got that? And then the last one is to use drugs directly to lower heart rate or lower cardiac contractility. Okay? Can you think of any drugs that when you give them to patients lower heart rate and cardiac contractility? Beta blockers, definitely. That's the top. What else? Non-dihydropyridine calcium channel blockers. They have direct cardiac effects. Okay? Everybody got that? So again, those are, yes, go ahead. Non-dihydropyridine calcium channel blockers, or NDHP, CCDs. Okay? Yeah, definitely. Dang out, go ahead.
Cardiac inversely related, if the field increases, the output increases, stuff like that?
Not necessarily. Now, if you have situations where you have extreme increases in afterload and you have a weakened heart, you can get blood that backs up into the left ventricle, and that can cause an increase in preload. Okay? But not necessarily the other way around. Okay? I don't even want you to think about that at this point, because we'll talk about that when we get to heart failure. Okay? I just want you to very simpler understand those three basic mechanisms by which we can reduce cardiac work. Reducing afterload, right, by dilating arteries. Reducing preload, okay, perhaps by dilating veins and reducing venous return. And that will reduce stroke volume and cardiac output. And then we have drugs that will directly act on cardiac tissue to lower heart rate and stroke volume, like beta blockers and non-dihydropyridine calcium channel blockers. So again, as you're studying this, just think about those three big mechanisms. Okay? If we want to improve coronary blood flow, I can think of 2 ways we can do that, right? What's one way? What do you think is one way, based on what you've heard already? Vasodilation, right? We can give drugs that will dilate the coronary arteries, right? What if the coronary arteries have a clot in them? Right, so we can use drugs to either prevent clot formation or break up clots, right? That's really it, okay? So you've got these 2 major categories, right? And within these 2 major categories, you've got like 3 different mechanisms that will reduce cardiac work and 2 different mechanisms that will reduce or improve coronary blood flow, right? So if you think about it like that, it can really help kind of throw these drugs into each of those categories, okay? You can get really tied up with a lot of the molecular mechanisms of action here of these drugs, like glutathione transferase and things like that. My advice is don't worry about that right now. Worry about those major effects. Does the drug reduce cardiac work? Does it improve coronary blood flow? Does it do both? And then what's the macro level mechanism for that, right? If it reduces cardiac work, does it directly lower heart rate and stroke volume? Does it reduce preload by reducing venous return? Or does it reduce afterload or systemic vascular resistance, okay? And then on the other side with the coronary blood flow. Everybody got that? All right. All right, so back to the nitrates. This particular figure, it says everything that the last one did, it's just a colorful picture. For those of you, if you like pictures, if this makes more sense to you, and I love it, that's why I still include it, okay? Organic nitrates, really good at reducing preload. Look how big these veins are down here, right? They're dilated. Venous return is low, preload is low, okay? That reduces myocardial oxygen demand. Organic nitrates also reduce afterload. Okay, that will reduce myocardial oxygen demand or work, right? And it also improves blood flow, coronary blood flow, by dilating the coronary arteries. Okay? That's it. If you know those 3 things, you can navigate about 80 to 90% of this stuff here. Okay? Yes, sir.
So, vasodilation. I don't understand the difference between the vasodilation and vasodilation.
Yeah.
So, vasodilation is relaxation of the artery.
Exactly. That's a term applied only to relaxation of arteries. Vasodilation equals arterial dilation. That it's only applied to that. Venodilation is your veins. Only dilation of your veins. And I used to get very confused about that too when I first learned it. Okay? So that you have those 2 terms. Venodilation only applies to relaxation and dilation of your veins. Veno. Okay? Vasodilation refers to arterial dilation. Only.
And what's venoconstriction?
And vasoconstriction, same thing. Venoconstriction is constriction of your veins. Vasoconstriction is constriction of your arteries. Okay? So thanks for clearing that up. I mean, that's really important to know. Okay? Here we go, right here with the dose-dependent effects of the nitrates that I mentioned before. Okay? At lower doses, okay, you get dilation of the arteries in the vessels of the skin as well as the meningeal vessels, and this can cause flushing and headache, which are common side effects of your nitrates. Okay? As you bump the dose up, okay, you're going to get a decrease in both systolic and diastolic blood pressure. Okay? I mean, think about it, right? You're reducing preload and stroke volume. That's going to reduce cardiac output. That's one part of MAP. And you're also reducing systemic vascular resistance, which is another part. So you're going to get a drop in blood pressure with this. Okay? And you can also get a reflex sympathetic nerve activity. Okay, that can happen. Your heart rate can start to go up a little bit. Dr. Naeem's going to talk about that. And venous blood pooling. Right? This is where your veins relax. You get venodilation. Your veins relax. They get really big. Blood pools in the veins. You get a decrease in venous return, right? A decrease in preload. a decrease in stroke volume and cardiac output, right? So that's all involved with the venous blood pooling. So again, it's dose dependent, all right, effects. Adverse effects of your nitrates. We have vasodilation caused by dilation of those meningeal blood vessels in your brain. Oh, we have headache, which is one of your adverse effects. That's caused by dilation of your meningeal blood vessels. And it also can be caused by, kind of a rapid fall in blood pressure. Okay. Dizziness caused by vasodilation. Again, that also is associated with a rapid decrease in blood pressure. Weakness, same thing. Postural hypotension, right? When you sit up and get dizzy, you feel like you're going to pass out. Again, that's due to the vaso and venodilation. And then you can also get a rash, but this is only typically associated with the nitrate containing, the patches containing nitrates. That dosage form, okay? There's a patch form of the nitrates. All right? Yeah, it's time. Okay. Go ahead, take 6 or 7 minutes. We'll come back and talk about this. All right. Let me know if you have questions here. I'm here. Yes, sir.
I know that nitroglycerin effects were discovered because it was explosive, I think.
Yeah, that's where they discovered it. So nitroglycerin is explosive. So in fact, that's how they determine the kind of the hemodynamic effects of it, right? I don't know if you know that story or not.
Yeah.
When they were making dynamite in the 1910s, yeah, it's got
really well priced.
Yeah, exactly. Yeah, it's a cool story, isn't it?
Yeah. So like, I know that it's just a chemistry question. So like, if real nitrate also means explosive because of the nitrate.
Yeah, that's a good question. I don't know.
It's just like
it is a good question, right? So is it when you look at nitroglycerin, is the molecule in its entirety, or is it the nitrate groups? I don't know. Yeah, but I always loved that story. I thought that was always a cool story about that, right?
Es un journal club, es un journal club, lo vas a decir. Pero lo vas a decir que te van a hacer preguntas. O sea, tú vas a sentar y te van a cuestionar.
Pero eso, yo creo que eso no lo vamos a
¿Qué?
Sí,
lo
tienen para hacerlo.
¿Verdad, Ernesto?
¿Qué es?
El journal club que le expliqué a Heidi cómo es.
¿Verdad? ¿Qué fue que se lo dio?
La policía, no.
Así mismo. Fue feo.
No, y cuando estés haciendo Carla, tú vas a tener el audio que dice, no me va a dar tiempo, no voy a acabar, sácalo. Eso es lo que te va a coger en la mente. Y vas a ver 5 minutos, 3 minutos.
Esta doble. Porque primero el quiz y después 5 minutos. Y después tienes todo el laboratorio para que estés usando como pandereta. Como pandereta, literal. Eso es todo el lado.
Realmente Petre hemos empezado mal. Yo he empezado izquierdo.
A mí me dijeron que esto era más fácil.
Pero yo lo veo más.
Siento que es más fácil de dos.
Siempre esto.
Para mí que el pelota es más fácil es esto. Pero.
O sea,
cáncer.
Yo no sé por qué me está pasando este semestre, pero yo no he empezado con el pie izquierdo.
Yo
la verdad que
me
estudio.
siento que lo comí muy bien. clase en el verano y me acosté y me hice un carajo.
Pues
Que
todo.
en verdad yo sabía eso, yo llegué desorientada.
Pero no está ahí, por eso no yo te contigo. Me sentí
Yo no hice nada. O
Dr.
sea,
Cooley,
y la pregunta.
Yeah,
can you give us like an advice for this P3 year? Because we're feeling like a little bit motivated, we can say that.
unmotivated?
Yeah.
Yeah.
And we need like something to give us hope. Yes.
What is the source of your unmotivation despair? Is that what it is? Are you saying, or is it just boredom or exhaustion or?
It's a mix
Yeah.
of everything, I could say.
So I think that's the first important question you have to ask yourself is what exactly is causing demotivation? Right? Because you can't fix it if you don't really understand it. And so for example, if it's just like I'm already breathing in, I'm exhausted, maybe it's going on, it's really important to take care of. And give yourself, even if you feel like it's actually working, give yourself that time to take care of yourself. That's so important. I think this semester, one of the stressful things, I don't know how many in the past have this semester.
I don't know.
Do you have any? If you don't have any, you're lucky.
Yeah, we have like health,
Yeah.
we have
Let's go.
various.
Let's go.
Various projects.
So,
That can cause-
CGM?
I feel that it's more that people are like studying a lot and not receiving like the grades that
The study
you know,
goes on.
like, I
For
feel
the
that
next
that's
cohort.
one of the things because we're studying like pretty hard,
Yeah.
but I
No,
feel that I
we
started
we
this
have one more
semester with the
people
left.
for the other cohort. We still need more people.
I don't know how to do that translator, but
Yeah. I get it.
Like, oh my God,
You can do
what's
13.
happening?
Yeah. So that's the case, right? That kind of demotivation is based on frustration. Okay, I'm putting in all this work, but
Can't.
I'm not going to
Restart it. We already have, the data's already running.
So
We have 4 people behind. It's not gonna be people left. At least, like, it's like in a reviewer standpoint, is that what it was? I'm a reviewer, like, why this data doesn't
You
matter?
have to spend 15 hours and not see.
You can talk with, I don't know, I'm not an expert. Talk to Dr. McCollum.
You're gonna work really hard, but you're not gonna take very big hold.
Yeah, the baseline.
Now you can, we're gonna work hard. Working easier.
Yeah, but you're deviating from the growth.
There's a lot of material.
So it's MITT,
Other things going on.
which is not, because we're not doing a randomized control trial, but and our sample size is really slow. You should ask, how about Richard? Richard has well, next one. That's something that we need to keep in mind. Because everyone that I have worked with has an iPhone. I don't know who has an Android because it's supposed to work with Android phones. I don't know what's happening. But it's weird that both people that has Android phones it's not working.
Don't put off with your project.
I didn't know it's supposed to
Keep up with them. That is not. And I think this one. What you learned from the previous class. And angry innovation. We'll talk about that.
What?
Review that.
What?
The work you do upfront.
So that means they knew what I was talking about. There was just 5-10 minutes chance.
Yes, sir.
They have to start to
Talk to Dr. Moore.
Yeah, that's something new we're doing this year, right?
Yeah, so, gonna be the same thing?
I think so. The same format. It's gonna be the same format. So I think that quiz at the beginning will test you on concepts, and then we'll do, a case.
I think that the other thing is that we can go back so that we can because I don't want to like.
Yeah, and you know what? Here's the thing too. If you're struggling with that, I can help you with that as well too. Okay. I was very pleased with how the class did as a whole. I thought maybe the score would actually go down because of this, but not only did they stay, they went up even a little bit compared to last year. So there could be a lot of reasons for that, but it can be stressful. And what you have to learn how to do is when you're approaching a question, like I told you guys before, using a system to rank order them, and not dwell on it. If you don't know what the answer is, and you think B is probably got the highest probability of being right, pick A and move on. And even if you miss it, it's clean mess. What you don't want to do is make it a question on an error, right, and miss that question. We can talk more about that as well. Okay? But this is a challenge. It is a challenging semester. It's hard. Okay? It's a lot of major disease states, a lot of drugs. But the good news is they're all common drugs. Most of them are. You're going to run into. Okay? All right, you guys ready? Don't answer that question or lie to me. One of the two. I'm fine with that. Either option is okay with me. All right. Coming back now. Let's talk about some old friends that we should be delighted to see again, and that you'll see over and over again in this module. And these are our non-dihydropyridine calcium channel blockers, right? I'm not going to spend a lot of time on these because we've already taught them in hypertension. But remember that these drugs have 3 cardiovascular effects, right? They cause vasodilation, right? What else do they do? They reduce what? Heart rate and cardiac output by reducing stroke volume, right? Okay? So those are your 3 effects. Now, if you can remember that and understand what that means, it's really easy to make the leap to, do they reduce cardiac work?
Yes.
What do you think? Kingsley's got a complete yes over there. Do we agree?
Yes.
Absolutely we do, right? And how do they do that? Right, so they reduce cardiac output, right? By reducing heart rate and stroke volume, that reduces cardiac work, and they also reduce PPR, right? Or SVR and afterload, right? Perfect. Now, the other question is, do they improve coronary blood flow?
Yes.
Yes. How can they do that? By vasodilating the coronary arteries. That's it, guys. Okay? If you remember that, you're good to go. Okay? Because guess what? I've got a limited number of questions on this exam, and I'm not going to be asking you about the chiral nature of your non-dihydropyridine calcium channel blockers. Okay? So don't worry about that. But what I do want to know is that you know what I just told you. Okay? All right? Again, we've got this here. If you don't like words, okay? All right? We'll get back to the adverse effects. Hold on one second. All right? Here's the picture, and I'll go back to these in a second. But again, here's our picture that summarizes everything. If you can explain this or recreate it independently, you've got it, okay? We know that we're getting vasodilation of our peripheral arterioles, okay? Which will reduce afterload and reduce the work that the heart has to do, right? We do get a little bit of venodilation, but I don't even test you on that, okay? It's minimal. The big effects here are, again, the effects on the SA and AV node, which ultimately lead to a reduction in heart rate, okay? When we reduce SA nodal activity and the conduction of electricity through the AV node, that will reduce heart rate, okay? And then we've got our effects on the cardiac muscle cells right here, cardiac myocytes. Okay? All right? And that causes a reduction in cardiac contractility, okay? Reduces muscle tension, reduces oxygen demand and work, okay? And then we have coronary arteries here, okay? So we've got vasodilation of your coronary arteries, which improves supply. So those three things that we just talked about, okay, are all shown here in this particular picture. Now, if you get this, you've got the non-dihydroperids, okay? Let's go back a little bit here, just so I don't want to move through things too quickly. Here's our diltiazem, okay? Don't worry about the med chem. Again, we know that they block L-type calcium channels that exist in the SA node, the AV node, cardiac muscle, and vascular smooth muscle, okay? The vascular effects of the drugs, we've already talked about this, right? They cause arterial vasodilation. They dilate arteries and reduce SVR or afterload. This will reduce cardiac work, okay? They also dilate your coronary arteries, which will improve blood supply or blood flow to cardiac tissues, right? We've already talked about that, okay? So those are your big vascular effects. The direct effects on cardiac tissue is, again, all this stuff here, you can summarize by saying it reduces heart rate, it reduces stroke volume, and reduces cardiac output. That's it. You can replace all of this nonsense here with reduce HR, reduce SV, reduce CO. Okay? That's all I'm trying to say there. You got it? All right? Now, side effects, again, are just an extension of what these drugs already do when taken to the extreme, right? We know that these drugs will reduce heart rate, right? If a patient gets too much of them, that can lead to abnormally low heart rates, bradycardia, okay? Okay? If this is accidentally given with a beta blocker, right? That's not good, right? There's a drug interaction there. You can get a really serious decrease in heart rate, okay? Through two different mechanisms, okay? Bradycardia is the big one. You can get a type of arrhythmia called a heart block, okay? And because these drugs slow electrical conduction through the AV node of the heart, okay, that can cause heart block, meaning that it can slow that electrical impulse down so much, okay, that you can get uncoordinated contraction of the ventricles in atria in extreme conditions. You'll learn about that in arrhythmias, okay? Bradycardia is the big one here, that's why I have it in bold. And then, again, other cardiovascular effects, hypotension, flushing, dizziness, headache, again, due to falling blood pressure, dilation of arteries, especially in the head, in the brain, okay? We also know that these drugs can cause constipation by relaxing smooth muscle in the GI tract, okay? Another weird side effect, this is always a great board question for diltiazem, okay? So pay attention to this. I won't ask you on the exam, but it could be a board question, this is one of the few drugs that causes gingival hyperplasia, okay? Enlargement of your gums, okay? There's another drug that does this. I believe it's a drug used to treat epilepsy. Phenytoin does it? Yeah. Years ago when I haven't taught CNS in a long time, but yeah. So again, that's a weird, it could be that's a slam dunk board question right there, okay? I don't know why they asked, but, you know, all right? All right, so we have verapamil here, okay? Don't worry about the medicinal chemistry, okay? Again, same molecular effects. Targets L-type calcium channels in the heart and in blood vessels, okay? Vascular effects, again, identical to diltiazem. We get vasodilation of arteries, vasodilation, okay? which reduces afterload and systemic vascular resistance. Okay. And again, with cardiac effects, you got a lot of words here. You can totally replace that with down arrow HR, down arrow SV for stroke volume, and down arrow for cardiac output. Okay? That's exactly what I'm saying there. Reduces heart rate, stroke volume, and together, that gives you a reduction in cardiac output. Cardiac output is a reflection of the work that the heart does, right? It's the amount of blood pumped by the heart per minute. So if we reduce cardiac output, we're reducing the work that the heart has to do. And that, in turn, decreases oxygen demand. Okay? Everybody got that? Cool. Okay, cardiovascular adverse effects. Again, if you know diltiazem, you know verapamil. Constipation is the same here, too. And I think constipation might be a little bit worse with verapamil versus diltiazem. Okay? Don't quote me on that. But pay attention when Dr. Naeem talks about that. She may have already mentioned that. Okay, but it does cause constipation as well. Right? Again, this table you've seen before, right? This is just comparing the non-dihydropyridines to the dihydropyridines. You don't even need to worry about this, all right? If you know what the difference is between those two, great, because I do want you to know that, okay? But all you need to know is that diltiazem, verapamil cause arterial dilation, okay? They reduce heart rate, and they reduce stroke volume. If you know that, you can X out this slide. You don't need it, okay? It's one less you have to look at. And we've already talked about this, okay? If you understand the hemodynamic or cardiovascular effects of these drugs, it's not too difficult to figure out if they reduce cardiac work, if they improve coronary artery blood flow, or both. Okay, everybody got that? All right. Yes, Dave Mallett.
So does the diltiazem and verapamil reduce preload too?
No, they don't. Okay, maybe, look, it says minimal venodilation, maybe a little bit, but they reduce cardiac output by direct effects on cardiac tissue. So they suppress the SA and AV node, which lowers heart rate, and they directly block L-type calcium channels in cardiac muscle cells so that they can't contract as forcefully, and that reduces stroke volume. Okay? All right, and reducing cardiac output.
Affect the preload because stroke volume affects preload, right? So
Nope, preload affects stroke volume, not the other way around. Preload is the amount of blood in the left ventricle prior to contraction, right? Remember, the more blood in the left ventricle before it contracts, the more stretched the cardiac muscle is, and the more forcefully it contracts. That's the Frank-Starling mechanism, okay? So again, there's two ways to reduce stroke volume, okay? You can reduce preload, and stroke volume will get reduced through that Frank-Starling mechanism, or you can use a drug that directly works on cardiac muscle tissue, like non-dihydropyridine calcium channel blockers or beta blockers. That will reduce contractility, and that will reduce stroke volume, okay? All right. Any questions about non-DHPs? All right. So let's talk about ranolazine. All right. This is a drug that is used. I even talked with Dr. Naeem today about should I cover this or not. She says yes. She's going to talk about it. It does come up. I'll try to keep it as simple for you as possible. There's chemical structure. I don't have any structure-activity relationship for you. Let's move on. Okay. Yeah. All right, yeah, I guess we're going to have to do this. Unfortunately, I hate doing this, but we're going to have to do it. You know what? Maybe not. You guys remember when you were younger, and maybe some of you don't remember the please stand by on the television, right? When things would go wrong with the television. Just please stand by for 2 seconds while I think about this.
Pequeño.
O farmacéuticos. Y en la primera,
All right. You guys remember back in biomed, right? Dr. Joshi talked to you about action potentials, right? All right. And the action potentials that are generated by a cardiac muscle cell look different from those that are generated by the SANAV. Okay. Now, when heart muscle tissue, okay, experiences ischemic conditions, these are conditions where it's not getting enough oxygen to meet its demand for oxygen, right? It's not getting enough oxygen to do the work that it needs to do. Cardiac muscle tissue can become damaged, okay, due to lack of oxygen. And what that will do is that ultimately, when you look at it on a molecular level, right, when you look at an individual cardiac muscle cell and what's going on electrophysiologically, that damage can manifest itself as changes in ion movement across a cardiac muscle cell membrane, okay? And ranolazine can help to reverse that dysfunction, okay, that electrical dysfunction, okay? What happens here is that there is a, if you remember in phase 0 here, okay, in this action potential, do you remember what kind of ions flow into the cell? Sodium, right? It's explosive, it generates a huge electrical signal. Sodium channels open, sodium rushes into the cardiac muscle cells and causes a massive depolarization, right? Now, at the end, as we get towards the end of phase 0, about 90% of those sodium channels will close. They go inoperable, right? But a small fraction of them stay open, okay? And that is referred to as the late sodium current right here, okay? The late sodium current. And those sodium channels will stay open during phase 1 and phase 2. And they're really important in some of in regulating the movement of some of the ions that are going across the cell membrane and establishing membrane potential. But at any rate, when a cardiac muscle cell is damaged, okay, what happens is that the late sodium current here gets larger. So instead of 10% of the sodium channels remaining open at the end of phase 0, you might have 20 or 30 or 40% of them staying. I'm making up some numbers here just so you can see. And what that does, and I won't get into how that happens, okay? But what that does is it causes your cardiac muscle tissue to become overloaded with calcium on the inside. It just causes way too much calcium to build up on the inside of your cardiac muscle cells. And that can cause abnormal contraction of the muscle, okay? It can cause abnormal contraction of the muscle, okay? And that causes the heart muscle to do, okay, a lot of work. Let me show you what, so you can experience what's happening here, okay? If you hold your arm out straight and you just tense up all the muscles, can you do that in your arm there? And just hold it like that. You see how mine's shaking because you're squeezing those muscles so hard, right? How does your arm feel after a few seconds?
Tired.
It feels tired, right? Because your muscles are contracting so hard. Guess what? That's exactly what's happening in your heart tissue. That calcium builds up and it causes that cardiac muscle to contract and be really, really tense, right? And that causes that muscle to be doing a lot more work and increasing oxygen demands. Everybody got that? Okay? That is essentially what's happening here. Damage causes an increase in the late sodium current, okay? That in turn causes your cardiac muscle cells and tissues to get hyperloaded with calcium, which leads to an abnormal contraction of your cardiac muscle. It just gets tense and stiff and contracted. And it's working so hard, just like your arm did. You know, you feel tired after a few seconds, right? Well, imagine your heart muscle doing that all the time, okay? And again, when your heart's tense and your heart muscle is contracting a lot abnormally, it's hard for it to relax during diastole, okay? So the calcium overload, again, causes all of these things to occur, all right? Mechanical dysfunction in terms of the way the heart muscle is contracting and relaxing. It also increases the wall tension when your heart muscle is relaxed, okay? Do you ever get really tense about something and nervous about something and you feel like you're all like crunched up, right? You know, and you know, you can feel your muscles in your neck and your shoulders are all tense. And then later on, after whatever is causing that passes, and you just kind of relax and you're like, oh yeah, right? That feels really good. That, you know, that tension that you're feeling when you're anxious like that is kind of analogous to that increase in diastolic wall tension, right? You should be relaxed, but you're tense and your muscles are all constricted, and you know you're doing a lot of work there that you don't need to be doing. Okay? In the heart muscle tissue, when the wall tension, the diastolic wall tension is high, what happens to your coronary arteries on the surface of your heart? They can flatten out like this. Okay? So when your heart muscle is in diastole and relaxed, usually your coronary arteries are nice and relaxed and wide open like this. That allows for blood to flow to different tissues in the heart during the relaxation part of the cardiac cycle. But if your heart relaxes and the muscle is still tense and constricted, that can cause those epicardial surface coronary arteries to flatten out. Look how flat that is. Can blood flow through that very well? No. Can it flow through this really well? Yes, right? But that diastolic wall tension causes your coronary arteries to flatten out, reducing luminal space and reducing blood flow, okay? So all these kind of things are going on as a result of ischemic heart disease. Ranolazine can reverse this to some degree, okay? What does ranolazine do? Good question. Let's get to it, all right? Ranolazine is essentially a sodium channel blocker. That's its molecular effect. It blocks the late sodium current, right? Remember, in ischemic heart disease and a lot of cardiac muscle tissue, that late sodium current is abnormally high due to damage to the muscle, okay? Ranolazine can block that and reduce it back towards normal levels. And that can cause a reversal, okay, in the calcium overload. Okay? That can cause a reduction in that calcium overload. Yes, Ernesto.
So this one, like this late LA current dysfunction is this like after it's getting ischemic?
Yeah, exactly, right? So if we have normal healthy hearts that are getting plenty of oxygen, that you don't see an expansion or growth in that late sodium current that can lead to calcium overload. But if you have, a diseased heart, or you've got coronary artery disease, and you've got, let's say, your left ventricle, your left coronary artery is blocked to some degree, and your left ventricle is not getting enough oxygen over time, that damage can accumulate, leading to an increase in the late sodium current, calcium overload, and now you've got mechanical dysfunction in your left ventricle, where it's always tense and contracted to some degree. It can't relax. Blood flow is further impaired. It's just a mess, right? And so what ranolazine can do is it blocks the late sodium current, right? It will reverse the calcium overload, okay? And again, reverse some of this mechanical dysfunction that we just talked about, okay? Returning the heart to a more normal contraction and relaxation cycle, okay? Reducing wall tension, cardiac muscle wall tension during diastole or relaxation, which will open up those coronary arteries, okay, and allow for better blood flow. So when we talk about ranolazine at a very high level, it reduces cardiac work, right? By just essentially allowing your heart to relax a little bit, right? Removing that tension and mechanical dysfunction, okay? You ever get a muscle cramp after exercising, right? And that's the way I like to think about it, right? If you massage it a little bit, maybe use a heat pad or whatever, and you start to eliminate that, and it just starts to relax and it feels a lot better. Now you can use your leg muscle better. And that's kind of the way I like to think about this. It may not be the same thing, but it helps me to visualize it, okay? Ranolazine can help block that, return that mechanical function to normal levels, and improving coronary blood flow. So it reduces cardiac work, okay, and it improves coronary blood flow. All right, you got it? The hard part about it is really understanding this nonsense here. It's not nonsense, but it's just a lot of detail, right? Okay. I think just understanding that, hey, when cardiac muscle tissue is constantly exposed to ischemic conditions, it can accumulate damage over time, and that changes the late sodium current, increases it. Yes, Dagmali.
So is calcium overload a good thing because we use
It's a bad thing. Yeah, calcium's one of those. It's one of those double-edged swords, right? In muscle tissue, too little, and the muscle can't contract very forcefully, right? Too much can actually be incredibly toxic to the muscle tissue, and it can overactivate contractile proteins. Okay, so your muscle tissue, whether we're talking about smooth muscle, whether we're talking about cardiac or heart muscle, or skeletal muscle, has a wide range of mechanisms and expends a lot of energy to ensure that they regulate intracellular calcium levels appropriately. Because like I said, too little, the muscle can't contract well. Too much can actually be toxic to the cell and cause, again, mechanical dysfunction in terms of the way the muscle operates.
But that's not when you use calcium blockers, right?
Yeah, you wouldn't use calcium channel blockers in this. That doesn't work that way. The dysfunction in this case is not due to like a dysfunction in an outside calcium channel. If it was, we might be able to use diltiazem or verapamil, right, to reverse this. The dysfunction is in the sodium channels. And then through a secondary mechanism that I didn't talk about, that can lead to calcium overload in the heart muscle tissue. So if we block the sodium current, that calcium overload reverses and then returns to normal levels. There's a big question mark in between those two because I didn't talk about that. I used to, but I don't anymore. Okay, if you're interested, I can explain it to you later on. Okay?
But in this case, it's helping.
It's helping, definitely, yeah. So blocking the sodium channels in the late sodium current will reverse the calcium overload, bring cellular calcium levels back to normal levels, allowing the heart muscle to contract normally and most importantly to relax normally. Okay? All right? I know this is the hard one right here. Any other questions about this?
So my guess is that when the patient comes in with an ischemic disease,
Yeah.
that typically causes the establishment because naturally the most maybe that would be for clinical.
Yeah.
Because most natural therapy you want to use the calcium channel blocker immediately.
Yeah, so that's a really good Kingsley. So Kingsley's question is really, and if I can paraphrase a little bit, when you're choosing what type of drug to use, right? Does that really depend on the cause of the ischemia? I think that I would save that question for Dr. Naeem. Okay. Again, we're always going with the clinical guidelines. All right. And ranolazine isn't used all the time. It's only used in very specific circumstances. In terms of it's not a first line agent we see used. I don't think. Okay, if I remember correctly, but it is used fairly frequently, and she's going to talk about it. Okay. Otherwise, I wouldn't spend time on this. All right, because it is a lot of time spent. All right. All right. All right. So let's talk a little bit about the coronary blood flow and hemostasis. Right. So far to recap, we've talked about organic nitrates, right? Do they reduce cardiac work? Yes. Do they improve coronary blood flow?
Yes.
Yes. Okay. Start there. Don't worry about the details. Start there. Non-dihydropyridine calcium channel blockers. Do they reduce cardiac work?
Yes.
Yes. Everybody yes together, right? Do they improve coronary blood flow?
Yes.
Yes. That was our second group, right? Ranolazine. Does it reduce cardiac work?
Yes.
Yes, it does, right? By preventing that abnormal contraction, allowing the heart muscle to relax. So that will reduce the work it does. It's like taking this arm that's really constricted, right, or tense, and then just relaxing. Okay? Does it improve coronary blood flow? Yes. Okay? Beta blockers. Let me ask you about that. We didn't talk about that. Do beta blockers reduce cardiac work?
Yes.
Yeah, for sure, right?
Yes.
Do they improve coronary blood flow? No. Okay? All right? So again, if you know how the drugs work, what their cardiovascular effects are, you can make a pretty good prediction, even if you don't remember it, right? In terms of how they work here, what system do they work on? Nitrates, non-dihydropyridine calcium channel blockers, and ranolazine all work in 3 different ways, don't they? They do the same macro stuff, right? They all reduce cardiac work and they all improve coronary artery blood supply, right? But they do it very differently on a cellular molecular level. Okay, that's where you get the details. Okay, but start big. Always start big here. Don't jump into the details. See if you can get them categorized right first, then start working down some of the details. Okay? All right, good. Let's talk about hemostasis here. Again, you talked about this in Applied Biomedical Sciences workshop. So the drugs that we're going to talk about from this point forward are hemostatic drugs. Okay? Drugs that prevent hemostasis or blood clots from forming. Okay? All of these drugs only work in one way. They don't do anything with cardiac work. Okay, they don't have any effects on cardiac work, but they will help maintain or improve coronary blood flow. Okay, does that make sense to everybody? Okay, now let's talk about hemostasis, just as kind of a background, so we can all get up to speed together. Okay. Hemostasis is a term that generally describes the body's biochemical and physiologic processes that it will use to stop bleeding. And I'm very deliberate in saying there are biochemical components to this, and there are physiologic components to this. Okay? Very complex process hemostasis is. Okay? Now, there's a couple of components of the hemostatic system. Okay? We have the blood vessel wall. Okay? So bleeding comes from an artery or vein that's been damaged, right? So the blood vessel wall is going to play an important role in preventing bleeding. And the body's got a natural process that it uses to prevent bleeding. Otherwise, if you cut your finger badly and you start bleeding, and you didn't have a hemostasis, a functional hemostatic process in your body, you'd bleed to death, right? Right? Platelets are another important component of the hemostatic process, okay? And the coagulation cascade, clotting factors, right? You remember the coagulation cascade, which produces fibrin strands at the end of it, okay? So these are the 3 major areas that we're going to take a look at with regards to the hemostatic process, the process your body uses to prevent abnormal bleeding from occurring. Okay? The body also has its own natural fibrinolytic system. That word fibrinolytic is a big word and it sounds confusing, but when you break it down, it makes sense. The first part of that word is fibrin, right? Fibrin is a polymer, an organic polymer that's produced as a result of the coagulation cascade. And it's an incredibly important part of venous clots, okay? And it's an important part of arterial clots too, but not to the same extent. So fibrinolytic. Lytic is something that cuts or breaks down. So your body has a collection of enzymes in the blood that when turned on will break down clots by chewing up fibrin. That's fibrinolytic. That's the fibrinolytic system. And we actually have drugs that will turn that system on and enhance it. Okay? Those are your fibrinolytic agents. Okay? Now, in your body all the time, there's a normal balance between clot formation and clot breakdown. Right now, you have clots that are formed in your body right now that you don't even know. Okay? On a microvessel level, you know, maybe even on a macro, hopefully not on a macrovessel level, but maybe you do. Okay? And clots are in many cases a good thing because they keep you from bleeding to death, right? But if they form in places where they shouldn't, i.e. on the inside of blood vessels, they can occlude or block blood vessels and prevent blood flow to certain parts of the body or certain regions of the heart. Okay? But normally there's a natural balance between clot formation and clot breakdown. We can use drugs to kind of disrupt this balance and achieve the outcomes that we want with this from a mechanistic standpoint. Okay? All right. This is a flow diagram showing you the different parts of hemostasis. Okay? We're going to focus on the left side of this flow diagram, your left, right? My right, where the red arrow is. This part of the hemostatic process over here, shown by the red arrow, is called primary hemostasis. Okay? Primary hemostasis. Okay? This is kind of what happens initially, especially on the arterial side of circulation. That's why it's primary. It happens first, and quickly. Okay? We start up here. This side over here, just for your FY, and we'll talk about it later on. What do you think this is called over here? Secondary hemostasis. Very good. Okay? That's why they let me teach this stuff, because it's, you know, right? It's pretty, they're like, yeah, you can call Hank and handle this, okay? All right, so we start up here with our damaged vessel wall. So a lot of times blood clotting is initiated due to some sort of vascular trauma, right? Okay? We smash our finger. We cut our finger with a knife, right? Or we get a paper cut. Or God forbid we're in a more serious accident where blood vessels in the body are traumatized and damaged, okay? That initial trauma, okay, and that's not the only reason the blood clots form either. We'll talk more about that, but that's one way, okay? That can kick off a series of events that involve your platelets, okay, that allow for the formation of a initial plug that will plug up the rupture in the blood vessel. Okay? And there are, I like to think of this as the 3 A's of hemostasis that involves your platelets. We have platelet adhesion, we have platelet activation, and aggregation. Okay? This is a very dynamic process here, and it helps to kind of visualize what's going on, and we'll go through that in a minute. That is one part of, in many cases, of a thrombus or clot, especially in your arterial circulation. Okay. Secondarily, what we can get is activation of the coagulation cascade on the surface of these platelets, which will form fibrin strands that will reinforce and strengthen the clot. Because that platelet plug that forms very quickly is not very strong, but it's a good temporary fix until fibrin strands can form around those platelets and reinforce them and strengthen them. Okay? All right. Then we have fibrinolysis and thrombus dissolution down here. So let's dig more into this here. Okay? So let's go back up to the top here when we talk about blood vessel injury. Okay? So injury to any type of blood vessel, especially an arterial blood vessel, but this can happen in veins as well too. And the blood vessel wall injury I'm talking about could be traumatic injury, you know, again, a cut or a crushing injury or something like that, or it could be due to a ruptured plaque. okay? That's another type of tissue or vascular trauma that can occur. One of those unstable plaques that I talked about at the beginning of the lecture, if it busts open, okay, that is a form of vascular trauma, okay? That can cause constriction of the blood vessel right around the site of injury. So the smooth muscle surrounding the area that's damaged or where the plaque is ruptured will start to constrict. And that is done to limit blood loss. Okay, so your blood vessels will constrict down when they're damaged to prevent blood loss from that damaged area. Okay, and again, there's a lot of reasons why your blood vessels will constrict in an area of damage. It's due to kind of pain reflex, all right? Or when the blood vessel tissue is damaged, okay, it will release vasoconstrictive substances from damaged cells into the blood right around where the damage has occurred, causing your blood vessels to constrict, okay? So again, a couple of different things causing constriction of your blood vessel. And again, the purpose of this is to limit blood loss, okay? All right. Now, I have a couple of different pictures of the primary hemostasis. What I'm going to recommend for you, okay, and I don't know why I haven't updated this, but it's so much easier to see this process, like on YouTube, on a video. I would recommend going to YouTube and looking up primary hemostasis, an animation of it, okay, to really kind of see what's going on here, okay? But if you want to see a picture here, okay, you can kind of see, all right, what's happening. And let me see if I have a different picture of this. All right. So what we're going to do here, well, no, we're not, because we have like 2 minutes left, okay? We're not going to do that. So that's what actually, that's going to be your homework for tonight, okay? I want you to find a YouTube video that looks good. Share it with people if you like it, okay? That will kind of show you what's going on. And I'll see if I can find one myself. If I find one that I really like, I'll send it out to you, all right? But you should be able, there are a ton of them out there. When we come back tomorrow, we're going to kind of work through this process, maybe even act it out a little bit. That can be very helpful, okay? All right, you guys did a lot of heavy lifting today. I did a lot of heavy lifting. Let's give me a round of applause here, right? A lot of stuff today. Good work today. Good way to hang in there. We'll see you tomorrow, okay? And let me know if you have any questions. I'll be here after class, all right?
Yes.